Welcome to St. Luke's Health Now, a show dedicated to giving you the most up-to-date information on cutting-edge medicine. I'm your host, Ashley Russo, and we have a fascinating show tonight. We're talking about minimally invasive neurosurgery. That's right, procedures available right here at St. Luke's to approach a variety of neurological illnesses and concerns without the downtime of traditional brain surgery. We'll be joined by a panel of the leading physicians in this field, hearing stories of patient success and taking questions from our live studio audience. Stay tuned. This is St. Luke's Health Now. Coming up on this episode of Health Now, an in-depth look at neurology with St. Luke's University Health Network. Stay tuned. Thanks for being here. Let's get started. We have a top-notch panel of guests today on Health Now. Joining me first is Dr. Doron Rabin, a fellowship-trained neurosurgeon dedicated to the surgical treatment of neurological conditions. Dr. Rabin works closely with family physicians, pain specialists, and neurologists to diagnose and treat degenerative, surgical, thoracic, and lumbar spine disease. He also provides surgical management for normal pressure hydrocephalus, also known as NPH, and performs over 100 spine surgery procedures each year.
For me, I think it's really important to take a little bit of extra time and understand how the patient's symptoms are impacting on their daily activities. As far as my spine practice, I do a lot of minimally invasive spine, and I would say probably about 90% or more of those patients go home the same day. I never offer people surgery that I don't think is going to help them, or where I think the risks of surgery significantly outweigh the benefits for them. We really pride ourselves on good communication between services, and so I think that's really kind of important because people start to understand that they're really being looked after as a person. I think when a person comes to St. Luke's, you're going to find a very different approach to healthcare than you might elsewhere. At the end of the day, when the person comes back in and is doing better and is happier and they have a better quality of life and we've helped them regain some of that quality of life, I mean, that's incredibly satisfying, and as a doctor, as a physician, it really keeps me motivated.
Dr. Rabin, thank you so much for being here.
Oh, no problem. Thank you for having me.
When people hear neurosurgery, they immediately think brain, head, and yet you work so much with the spine. Can you explain how the spine is connected to neurosurgery?
Absolutely. You know, the brain and the spinal cord are really kind of all one big system. The way I think about it is the brain is kind of like the computer system for the body, and the spine is how it gets its signaling out to the body to tell us to move, to get sensation back, so our brain interprets the world around us. And of course, just like the skull kind of protects the brain, the spine protects the spinal cord, allows us to move our neck, our back. So really, they're intimately related in one continuous system, basically.
Great information, Dr. Rabin. Thank you. Joining our panel next is Dr. Hugh Moulding, a fellowship-trained neurosurgeon and the clinical director of the St. Luke's Brain and Spine Tumor Center. Dr. Moulding oversees the multidisciplinary management of individuals who have been diagnosed with tumors of the brain and spine. He's also the principal investigator for clinical trials in neuron oncology at St. Luke's and performs a variety of procedures, including image-guided brain tumor surgeries and stereotactic brain and spine radiosurgery.
One of the reasons I said I wanted to come practice here is that the St. Luke's family really has commitment to the latest, most innovative, most effective technologies. The best treatment isn't always the same thing for everybody. So I think we focus very much so, especially at the Brain and Spine Tumor Center, on taking care and managing the entire situation. We are talking with you as the patient about your options or tailoring these plans to each patient's scenario. It's always been a privilege to take care of patients that, at a very difficult time and don't often know where to turn or what to do or what would be next or where things are going to go. That's been a huge part of how we've developed our program, is that we do work so well together across different specialties and collaborating with my colleagues. And so focusing and tailoring our treatment approach, our treatment goals for each patient, I think is very key to us.
Welcome, Dr. Moulding. Thanks for being here.
Thank you for having us.
So you specialize in tumors. How common is a brain or a spine tumor, and what do people need to know, and how concerned do they need to be? Is this a common thing?
Yeah, actually, it's surprisingly, brain tumors are very common. Typically, and thankfully, a lot of those brain tumors are benign. So some studies show even 5% of people walking around have a benign brain tumor they'll never know about. A lot of times we find them incidentally if someone has a headache or in a car accident or something like that, and many of those times we're just able to follow them and kind of make sure there's no signs of progression or symptoms down the line. I mean, obviously there are certain types of tumors that are more aggressive, malignant, and the good news about that is that we have a lot of different technologies, techniques, and ways to address these that don't always necessarily mean a big surgery or a lot of downtime, and ways to control them in very positive, productive ways that get people back to their quality of life quickly.
Thank you very much, Dr. Moulding. Appreciate it. Let's meet our final panelist, Dr. Evan Marlin. Dr. Marlin is the newest member of the St. Luke's Neurosurgical Associates and completed his fellowship in endovascular neurological surgery at The Ohio State University Hospitals. He treats a variety of conditions and diseases of the central nervous system, including stroke and aneurysms, and works closely with St. Luke's neuroradiologists.
St. Luke's is a great opportunity. They have built a stroke network which provides excellent multidisciplinary stroke care for patients. The opportunity to become part of that team was very enticing. The general saying in neurology and neurosurgery is time is brain, so the earlier the better. Stroke is a complex disease. Not only does it affect the blood vessels, but it affects every aspect of a patient's life. My job, and the reason I do medicine, is to help navigate someone through those choices. Seeing a patient is a privilege. In addition to patients who come in with strokes, being able to get them back to their normal life is something that previously we haven't been able to do very frequently. So given the opportunity to do that is an amazing thing.
Dr. Marlin, thank you so much for being here.
Thank you for having me.
So as people age, they become more concerned with heart attacks and strokes. What do people need to know about the symptoms, and what kinds of things are you most commonly seeing in your patients?
Well, one of the most important things for patients to know is that when they have new signs and symptoms of a stroke, so specifically the acronym FAST, so face weakness, arm weakness, speech difficulties, that time is of the essence, so that they call the emergency services, get in an ambulance, and come to the emergency room. And strokes can be a variety of disease processes. So it could be blood not getting to the brain due to an occlusion or bleeding inside of the brain. But the best place to evaluate that is in the emergency room and then decide on what their treatment would be.
Thank you all for giving us a better basic understanding of your individual roles and the roles that your teams play in offering advanced neurosurgical services at St. Luke's. Coming up, we'll dig deeper into how the panel works together to solve complex brain and spine issues, what new technologies are available, and we'll hear from their patients and our audience later in the show. Stay tuned, we'll be back after a short break. You're watching St. Luke's Health Now.
The severe pain I had was jolts that were just, almost like lightning striking me, and it was quite painful. My daughter was a patient of Dr. Rabin's, and she told me, go see Dr. Rabin and Dr. Erickson, and I did, and it's been A-OK ever since. They were really great, and he's so personable. I mean, he was very thorough. He explained it's just going to be an incision about 1.5 inches, and I'd be in and out. I would just recommend Dr. Rabin to anybody. But my whole lifestyle, it's pain-free. I can do my weight training, and it's just been a miracle.
Welcome back, and thanks for being with us tonight. I'm Ashley Russo, and this is Health Now. I'm joined by an outstanding panel of neurosurgeons, Dr. Duran Rabin, Dr. Hugh Moulding, and Dr. Evan Marlin. We've discussed their individual roles, and now let's get a better understanding of some of the non-invasive neurosurgical procedures available at St. Luke's University Health Network. We want to thank our audience for being here today and providing us with such smart and interesting questions, which we'll get to later in the show. And a special thanks to our patient participants whose stories you're hearing throughout the episode. All right, Dr. Rabin, let's get started. You do a procedure called NPH, which stands for normal pressure hydrocephalus. Am I saying that correctly?
Yes, you are. Yes.
Okay. What is it and how is it treated?
So normal pressure hydrocephalus, we kind of think of water on the brain, but it's different than other forms of hydrocephalus. People, typically, they're going to have some problems with their memory and their thinking, their walking and balance. They'll have difficulties also with their bladder as well. That's the classic triad. At St. Luke's, we're very fortunate to have set up an integrated NPH program where they get a really thorough assessment with respect to whether or not surgery might be helpful for them. And the actual surgery for this is a procedure called a ventriculoperitoneal shunt. And basically, we're just diverting the fluid through a tube and a programmable valve down underneath the skin and into the abdomen, just to kind of relieve some of that fluid from the brain. And hopefully that improves their symptoms.
Dr. Moulding, you do a procedure that is known as LITT, L-I-T-T. What is that and who's a candidate for that procedure?
Sure. So it's an abbreviation for laser interstitial thermal therapy. Basically, it involves making a very small incision and a small burr hole in the skull to deliver a laser probe into a target inside the brain. Typically,
all right, well, that sounds scary right there. So you're drilling open my brain and you're shooting a laser into it, but I assume that you know what you're doing and it treats something. So tell me more about
Absolutely.
it.
Well, the good news is, as I said, it's a very small incision, a couple of millimeters, and the hole we drill in the skull, instead of being a large port or opening to access a tumor, it's the size or diameter of a coffee stirrer. So the recovery time, the incisional pain, much, much less. And once we very carefully, as you kind of pointed out, deliver the laser probe into the target, we're able to use MRI during the procedure to watch the laser turn on, activate, and destroy a tumor where it sits, as opposed to trying to make a corridor and taking it out. And we found the recovery is much less for the patient to have to go through. The infection risk is lower. There's a lot of side effects that we can avoid by this minimally invasive approach.
Amazing, and it's just such an advanced technique, and it's so cool that we have it right here in the Lehigh Valley.
It's been a great privilege to bring it here, yes.
Dr. Marlin, we're talking about all of these procedures, and as a neurosurgeon, how is this helping your job to know that these procedures are out there and these technologies are available right here at St. Luke's as you deal with these different issues with your patients?
So one of the great things about working with so many different physicians in the group and in part of a multidisciplinary team is that each patient gets their own treatment. And having so many tools to do that, whether it be through minimally invasive spine surgery, treatment of NPH, minimally invasive tumor surgery, or minimally invasive aneurysm surgery, they really have a whole gambit of treatment options in front of them.
Yeah, you mentioned the aneurysm surgery. I know that that's one of your areas of specialty. Tell me a little bit about some of the options for a patient coming in with an aneurysm.
So each aneurysm in each patient is different. Traditionally, the aneurysms were treated with open craniotomies and clippings, which is a big surgery. Fortunately, with technology and the way we've had advances in radiology and special techniques, we can now sometimes take catheters or little tubes, also the size of stirring straws or smaller, and go all the way up someone's leg, through their belly, through their chest, into their neck, and all the way in their head to deliver treatments to aneurysms or AVMs or other vascular malformations in their brain.
You're talking about procedures that really require a team and require multidisciplinary approach to all of these procedures. Dr. Moulding, how important is the communication and what can patients know about the way not only the neurosurgeons communicate, but the radiologists and the other doctors that you mentioned when you're doing something like brain surgery?
Well, I think we put a premium on communication at St. Luke's. It's part of the institutional culture, but it's also a big part of our group's dynamic, that we're very involved in communicating with our colleagues with whom we treat patients as a team, but also perhaps the patient's primary care physician, the referring physician, a physician they need to see after they've been involved with our care. So there's a lot of interrelated communication. We have programs that involve nurse navigators that help with these steps so that things and information and patients themselves don't fall through the cracks. So it really is a huge priority for us.
It's nice to know that when you come to St. Luke's, whether that be up in Miners or Monroe or New Jersey or Quakertown, you have access to this state-of-the-art medicine and to all of you really just with the click of a mouse. So thank you so much for all of this information. We're not done yet. This has been insightful so far, but there's more after the break. We're going to talk a little bit more about your options for minimally invasive neurosurgery. You're watching St. Luke's Health Now. Stay tuned.
I actually did not have any of the symptoms that would have indicated I was someone that could have had a stroke. I was 49 years old and I had a major stroke. I remember being wheeled into a room and there were just people waiting for me, and they did not hesitate whatsoever. I felt relief when I got to St. Luke's. The staff in the ICU were excellent. My nurse was wonderful. I'm actually very proud to say I'm associated with St. Luke's University Health Network. I don't have to go to Philly or anywhere else to get the care that I need.
Welcome back to St. Luke's Health Now, a show dedicated to giving you the most up-to-date information on innovative medicine. I'm your host, Ashley Rousseau, and we have an incredibly interesting show tonight. We're talking brain and spine health and what you need to know about your options for treating a variety of health issues. We're also hearing patient stories of success and taking questions from our live studio audience. In case you're just tuning in, I'm joined by 3 St. Luke's physician panelists, Dr. Duran Rabin, Dr. Hugh Moulding, and Dr. Evan Marlin. Thank you all for being here. In the first part of the program, we talked about some of the procedures available to patients, such as NPH, LIT, and we learned about your team approach and how that works. So now we'd like to discuss some other options that patients may have regarding their care. Let's dive into symptoms and additional treatment options. So, Dr. Rabin, I'd like to start with you. There's another procedure called ESI. That stands for epidural steroid injections. Can you tell me what they are and who's a candidate for that?
So, basically, epidural steroid injections literally mean introducing steroid into a very specific epidural space in and around nerves, usually along the spinal cord, basically, whether it's in the neck, in the thoracic spine, or lower down in the lumbar spine. Basically, the way I kind of see it, along a continuum of how invasive something is, first, if you have some back pain or neck pain, you try over-the-counter pain medications, physical therapy, then maybe some prescription medications. And then after that, you might progress to an epidural steroid injection where basically with fluoroscopy, a type of X-ray, the needle is introduced into that area and delivers the steroid to one part of the body, as opposed to taking, let's say, a steroid orally, and then it gets distributed everywhere in the body. Usually by the time somebody's come to me, they've tried things like that, if they're willing to try it. And then, on the next level in the continuum would be for me to offer them, if they're appropriate, a minimally invasive spine surgery. That's usually more for pain that shoots down into an arm or into the legs, though sometimes it can be effective for certain types of back and neck pain. And then finally, there's some patients where you just don't feel like they're candidates for a minimally invasive approach, and that might be when you kind of describe to them something a little bit more of a traditional open procedure. And I think really the important thing is to be familiar with all of these options so that you can really counsel somebody and say, well, I think this is really what's going to work best for you. And
take it in steps, so you know that you really try to go the non-surgical route first and never 100%. Know where someone might find relief or how far down the path they need to go.
The advice I typically give my patients is that, if you find yourself on an operating gurney heading down to the OR, you're not going to be happy to be there. Nobody is. You're nervous, you're anxious, and that's understandable. But if you've tried everything you're willing to try, and you know what the surgery can and can't do for you, at least you're going in with some peace of mind.
Absolutely. Well, Dr. Moulding, you do a procedure called frameless stereotactic radiosurgery. Tell us what that is.
Right, so that's a type of radiation that would deliver to targets, again, inside the brain. It's got a bunch of brand names people might have heard of: Gamma Knife, CyberKnife. We use a machine called TrueBeam. Basically, it's instead of radiation being given a little bit at a time over days, weeks, months to try and treat a target, a brain tumor, be it benign or a cancer, we can deliver radiation in one session at a very high dose in a very precise way with incredibly good efficacy at containing that tumor's growth, so 95% often. The frameless part of it is a newer advance that we've brought to the table. Traditionally, this gamma knife technique is involved holding someone very still. If you're trying to hit with radiation beams something that's 5 millimeters across, you can't sneeze, you can't move.
Right.
And that
we're all
involved,
used to that frame that we see on TV
that's
shows.
right, locking someone down literally, you know, with skull clamps to the table so they can't move during the delivery. The advances we've made is that we have a number of different cameras and laser grids that are applied across the patient's face while they're receiving the treatment, so that if they move even a fraction of a millimeter, we can see the machine pauses until they're back in alignment, and then the machine continues to deliver the treatment, all within 10, 15 minutes.
Absolutely incredible, it really is. Dr. Marlin, we're talking about minimally invasive, but there are invasive procedures. Can you tell me a little bit about the difference and when invasive might be the only option? And that's something you have to discuss with your patients as well.
So as with kind of every pathology we deal with, whether it's spine or brain tumors or aneurysms, unfortunately, non-invasive or minimally invasive methods of treating them don't work for everyone. And when that's the case, it could be an open surgery. So for aneurysm surgery, that often involves craniotomies and clipping of the aneurysms, and a lot of that depends on the size of the aneurysm, the location of the aneurysm, and the individual morphology of the aneurysm. With brain tumors, there's other factors that are similar, and same with spine. So having a multidisciplinary and kind of integrative group where they know how to manage both minimally invasive and open surgery is very important for the whole treatment of a patient.
Dr. Rabin, how quickly is this field evolving? We're talking about techniques that really haven't been around that long and that are developing rapidly. Do you have to really stay on top of this? Are you constantly learning something new?
Well, absolutely. I mean, you know, in any one of the areas we've been discussing, whether it's spine, brain tumors, or aneurysms and vascular issues, there's always new techniques coming along. And I think we really try to evaluate them objectively before we decide to bring them into the practice and offer them to people. So there's something called evidence-based medicine, where you're really trying to take a look at what the track record is with these things before maybe offering it to your own patients, really doing a thorough evaluation to say, okay, well, which patients would this apply to and which ones would it not?
Well, I have to say, I really have learned so much, and I think it's very interesting to know that there are so many options and things that really aren't quite as scary as I thought they were. So thank you all for that information. All right, up next, we'll get questions from our live studio audience. Stick with us. You're watching St. Luke's Health Now.
I was a runner. I was a runner for 40 years. I started falling down and a little disoriented occasionally. I just thought it was age at the time, so I went to St. Luke's. I just can't tell you how wonderful it was. The nurses, everybody treated me so well. I had a lot of confidence in Dr. Rabin. He was so professional. He saw the MRI and he explained what condition I had. He told me what the operation would be like. St. Luke's, believe me, amounts to a real lifesaver in terms of being able to function normally.
Welcome back to St. Luke's Health Now. I'm your host, Ashley Russo. A special thank you to all of our audience members, but especially our patients, for sharing their stories with us. And of course, to our wonderful panel, Drs. Rabin, Moulding, and Marlin. We've had a great discussion on minimally invasive neurosurgery at St. Luke's, and now we want to take some questions from our studio audience. So the first question, Dr. Marlin, I'm going to throw over to you. Our audience member asks, if I had a brain aneurysm, which type of minimally invasive surgery is right for me?
So I mentioned before, every aneurysm, just like every patient, is different. The best way to understand if an aneurysm can be treated through minimally invasive techniques is by starting by getting a good picture of it. And that's frequently done with something called a diagnostic cerebral arteriogram, which is a fancy name for me taking a small little tube, going all the way up the leg, the belly, the chest, and into the neck, and taking pictures of the blood vessels. And those pictures help determine what kind of treatment is available to that. And that can be coiling aneurysms, so putting a small tube into the aneurysm, putting platinum coils into it, putting special stents in the blood vessels, or balloons to assist in coiling. Or if none of those options are available, help determining the best approach for open surgical treatment.
Wow, but lots of options. Got to start with the pictures if you don't know what you're looking at. Okay, makes sense. All right, Dr. Rabin, Is there a connection between spine and neuropathy?
Well, so the interesting thing is they can kind of mimic each other. So sometimes people can have numbness, tingling, sometimes pain in their, let's say, their feet, which is related to neuropathy, and that means more that the nerves, let's say, in the feet themselves aren't conducting signals back up to the brain the way they used to, and that's, you can often see that in people with diabetes, certain type of nutritional deficits, though a lot of them are idiopathic, or we just don't know why they happen. However, sometimes issues in the spine, tightness in the spine, what we call stenosis, whether it's in the lower back or in the neck, can also cause similar symptoms. I generally, if I have a patient that comes in and I'm, after doing a thorough examination, I think there might be a peripheral neuropathy in addition to some issue with stenosis in the neck or in the back, I'll often send them for a special test called an EMG nerve conduction study. The surgery isn't going to help the peripheral neuropathy part, but it is hopefully going to help any part that's coming from the stenosis or the tightness in the spine. And it's important for the patient and myself to know that up front, because there are other things that can be done for the neuropathy down the road, including certain physical therapy techniques and things like that. So I'd say they kind of can mimic each other. Are they directly related? Not necessarily, but it's
distinguishing
important.
Between them is
Absolutely,
important right off the bat. Dr. Moulding, this audience member asks, does the minimally invasive approach work for every type of brain surgery?
So the short answer is no, but I think to mimic my colleagues here, it really is an individual patient assessment that we kind of have to make on all these different scenarios. So, for certain aneurysms, we want to use coils versus clipping the aneurysm. For certain brain tumors, the exact same scenario, the minimally invasive LIT technique isn't best suited for certain types of tumors, certain locations for tumors, et cetera. The details, the devil are in the details. But other times, it's the perfect solution. So, it's the saying that if all you have is a hammer, everything looks like a nail. We pride ourselves on having a wide array of tools so we can handle every scenario appropriately and not just the one way we can.
Great analogy, Dr. Marlin. This audience member asks, what are the symptoms of a stroke and how quickly do I need to get to the hospital to be safely treated?
That's a great question, and it's something that we kind of touched on. One of the most important things to remember is that the acronym FAST. So if you start having facial weakness, numbness, tingling, arm symptoms, leg symptoms, speech difficulties, time is of the essence. And for that, you need to call an ambulance, have EMS drive you to the emergency room to be evaluated.
And on that note, we're going to end the show this evening. Thank you so much to our panel for being here. Thank you so much to our audience and for all of you out there watching. For more information on neurosurgery or neurological care at St. Luke's University Health Network, please visit their website at sluhn.org or call InfoLink at 1-866-St. Luke's. I'm Ashley Russo. This is St. Luke's Health Now. Thanks for tuning in. Until next time, be well, and remember, it's important to focus on your health now.